The speaker for this presentation is John Prowle.
Hello everybody, my name is John Prowle. I join you here from the Royal London Hospital in London in the UK. On the 14th and 15th floor here, we have over 150 COVID ICU patients at present. So you'll appreciate it's very busy, but it's a great pleasure to join you. I'm going to share with you some thoughts today about fluid management at AKI, restriction or liberal. I can't answer this question. It's obviously come to the fore in our management of patients with COVID-19 pneumonia who are at risk of AKI, but also have quite complex fluid balance issues. I'm not going to talk too much about those patients today because there's a very large lack of evidence, but I'll allude to it because it's obviously the question of the moment. But really, and I've used this slide over many years, fluid therapy represents an existential conflict. We have the desire to resuscitate the patient's circulation, to restore renal perfusion, therefore restore urine output and renal oxygenation and prevent our classical understanding of acute kidney injury. But also over the last 20 years or so, we've really understood the adverse effects of fluid overload on the whole body and the kidney, and we're particularly keen to prevent fluid overload. But of course, it is extremely difficult to do both of these things. We've tried to encapsulate this approach in our kind of conceptual approach to intravenous fluid therapy in patients with shock, where we have a rescue phase where we deal with an acute volume deficit, an optimization, a stabilization phase, and eventually a de-escalation phase. But this ignores the fact that we inevitably will overshoot on rescue, and that capillary leakage and fluid sequestration causes our optimization and stabilization phases to be extremely difficult, and also the ability to de-escalate fluid in the latter stage of illness to be extremely challenging. And so this is nice in principle, in practice it's extremely hard. I've alluded to, but fluid overload can really have adverse effects on all organ systems. We obviously think of the lung, but the gut, the tissues, the liver, even the heart and the brain, and in particular the kidney can all be adversely affected by fluid overload. In the case of the kidney, then fluid overload causing worsening renal function can be a sort of a result in a positive feedback loop where that results in further fluid overload and a perpetuation of acute kidney injury. We certainly know that in patients who do develop severe acute kidney injury and eventually need renal replacement therapy, then the severity of fluid overload at the initiation of RRT is sort of linearly associated with increasing risk of death. And there doesn't seem to be a cutoff point. It's not that some level of fluid overload is accepted. It's kind of the more there is, the worse you are. But of course, hypovolemia in its own right is likely to be worse for you, and we'll explore that concept a little bit later on, because just because fluid overload is associated with increased risk of death doesn't mean that resolving the fluid overload with RRT is actually going to improve outcomes. That may be true, but it may not be true in every patient, and how you do it may affect your outcome. When we looked several years back now at a load of studies looking at fluid management in patients who already had AKI, then we didn't really find any studies that showed a benefit of being more fluid overloaded. And we showed a number of studies that did show benefit from resolution of fluid overload. But obviously these were almost all observational studies. And again, these are patients who've really got AKI as opposed to patients who are developing AKI. So really, there are a number of questions we have with managing patients. These are just some of them. But one is, to what extent is fluid overload a marker of illness severity, i.e. the extent to which you needed the original resuscitation? And to what extent is it an avoidable cause of iatrogenic morbidity and mortality? Because if the former is true, then perhaps to be more restrictive on the initial fluid resuscitation will actually cause harm. Whereas if the latter is true, then a more restrictive approach would probably be beneficial. Does fluid overload itself contribute to the initiation or persistence of AKI? Well, this probably is true. But the question is, can we treat this? Or is this sort of an inevitable part of the pathophysiology of the syndrome. And so really the question is, does the avoidance or treatment of fluid overload with RRT or diuretics improve outcomes? If so, when and how should this be performed? So very briefly, I'll go through again, and some of you have seen this before on many occasions, how the adverse effects of fluid overload may be mediated, in particular with regard to the kidney. So first of all, I'll have the observation that a high CVP predicts renal dysfunction in cardiac failure. There are a number of studies that have shown this, but this is just one that I like, which shows that CVP was much better at predicting worsening renal function than cardiac index in patients who were admitted with acute decompensated heart failure. And so it wasn't the forward flow, but the resistance to venous return in terms of the CVP and the congestion that was affecting the organ function more, and the prognosis for the kidney failure. We've made the same observation in sepsis. This is from Mathieu Legrand when he was in Paris, and he showed that the higher the mean CVP was, the greater the risk of new or persistent AKI in a group of septic patients. And this kind of ran in the face of the guidelines at the time, which suggested that one should meet a target CVP in the resuscitation of patients with acute sepsis. And those kind of suggestions have fallen away from the surviving sepsis guidelines, because in fact, achieving high levels of CVP may be associated with harm and don't necessarily correlate with adequate fluid resuscitation, whatever that means. So how might venous congestion cause or worsen renal function? Well, there's a lot of very old physiological evidence about this, but high venous pressure definitely decreases renal perfusion. This is the most elegant paper I've found on this from the 1930s, in fact. But basically an increase in venous pressure had an identical effect on reducing renal perfusion, causing uremia and reducing urine flow as a decrease in arterial pressure. And how does it do this? Well, an increase in venous pressure increases renal interstitial pressure. You move forward to the 50s. This shows a linear relationship between intertubular and peritubular pressure and an increase in renal venous pressure. And obviously increased intratubular pressure causes there to be require a greater intraglomerular pressure in order to get ultrafiltration, and therefore can effectively reduce GFR, particularly when renal perfusion pressure is poor. Fluids we know can cause renal swelling. This is an interesting sort of byproduct of a study where they were looking at fluid administration in healthy individuals and measuring renal volume by MRI. Two different fluids, but they both had a similar effect. In healthy individuals, your renal volume increases after just 2 liters of a crystalloid infusion. This percentage change in volume is small, but the kidney is an encapsulated organ, and changes in pressure are not linearly related. Changes in volume are not linearly related to changes in pressure. And a small increase in volume can result in a large increase in pressure within the closed box. As shown in this experiment in rat kidneys, when injection of volume to the abate small rat kidneys can produce large increases in pressure in a non-linear fashion. Importantly, when you get AKI, that independently causes raised interstitial pressure, presumably due to capillary and tubular leakage of fluid. And so even without venous congestion overall, after ischemia, you get increased subcapsular pressure in kidneys, and that may play a role in the maintenance of AKI. And this is because relieving the pressure attenuates AKI, and this is back to the group who were injecting fluid into kidneys, and they demonstrated that renal decapsulation was able to abrogate the pressure increases in the kidney. And when they did this in an ischemia reperfusion model, they were able, in the decapsulated kidneys, to reduce the level of tubular cell apoptosis and the histological score of tubular injury in their model. Thus, fluid overload, raised venous pressure, and interstitial edema may all contribute to the maintenance of AKI, and they therefore should be targets in our management of the patient with AKI. And this is shown here in this cartoon from a publication of mine from a few years back, really these processes all conspire to reduce the ultrafiltration gradient, which therefore reduces the ability of the kidney to excrete salt and water overload. And it's really until you can get the restoration of diuresis or resolve the fluid overload that you get the sustained improvement in kidney function as your boggy kidneys become less boggy. So management of the fluid balance in patients with or at risk of AKI is extremely important, but it is extremely challenging, as I've indicated. Really, we have to resuscitate appropriately early, but we have to understand what that means. And then what we do need to do is avoid the need for fluid removal as much as possible late by appropriately limiting intake. And we'll see in a little bit why avoiding the need for excess removal is particularly important. And so this is going into this stabilization phase where we're trying to prevent the fluid accumulation from rising any further. And it may be then that we need to think of early ultrafiltration or the targeted use of diuretics as a component in an active fluid management strategy to mitigate the effects of AKI and improve patient outcomes. This is an important caveat to when we're talking about resuscitation. So the relief study conducted in Australia a couple of years ago looked at a surgical population, was attempting to improve outcomes by pursuing a very conservative fluid management strategy that really aimed for euvolemia around the time of surgery, with the idea that this would be expected to limit fluid overload and reduce complications. And they were targeting a high-risk population. This was high risk of AKI as well as other complications. And really the investigators here felt reasonably strongly that their intervention would be likely to improve outcomes. They were two well-matched groups who underwent major surgery and were generally old and had comorbidities. The liberal regimen was kind of targeted towards standard fluid management around the time of surgery, which obviously involves the administration of crystalloid solutions both during the operation and as a degree of maintenance until oral intake is restored. Whereas the restrictive regimen involved a much smaller level of infusion and a higher reliance on vasopressors if hypotension developed, with an aim really to keep a kind of net zero fluid balance. Even then, they didn't keep a net zero fluid balance. The median fluid balance was plus 1.3 litres compared to plus 3 litres in the liberal fluid group, as you see here at the bottom. So the results of the study are very interesting. Overall, there was no improvement in disability-free survival with the restrictive fluid group, which was the primary outcome. But the renal outcomes were very provocative. There was a higher incidence of acute kidney injury overall in the restrictive fluid group, and even though the numbers are small, a higher incidence of the need for renal replacement therapy, suggesting that in this phase of the illness where resuscitation is the most important, around the time of major surgery, where there is venodilation and surgical fluid losses, really it's the resuscitation element of the management that's most important in preserving renal outcomes, and the effect of fluid overload that may be caused by this it may be less severe. Now, this is not to say that this observation would still be the same in patients in different clinical contexts, such as sepsis, who may be more at risk of the adverse effects of fluid overload. But it certainly is a challenge to the thought that fluid overload is the only problem. And certainly in the pre-AKI situation, adequate fluid resuscitation remains a paramount part of management. So this moves us on to consideration of how we might manage patients who have developed acute kidney injury in terms of their fluid balance. So as we've seen, many of these patients are fluid overload, and that's associated with adverse outcomes. And so you could argue that we should be managing these patients with renal replacement therapy in order to address this fluid overload. And potentially we should be doing that earlier before they accumulate more severe fluid overload. Now, we've talked a lot about RRT timing in the last few years. I haven't on this slide got the START AKI study because I've taken this from an old slide deck, but these were the two major studies a couple of years ago. the AKI study and the ELAINE study. And the AKI study is a large multi-center study and has been confirmed by at least 2 other large studies, showed no benefit from earlier RRT. The ELAINE study in the surgical population did show a benefit from earlier RRT. And the question is, why was that so? And can we leverage this observation? Because overall, starting renal replacement therapy just based on AKI criteria doesn't seem to be beneficial. Well, one observation about ELAINE was that part of their inclusion criteria include there to be some complication of acute kidney injury, one of which was some measure of refractory fluid overload. And actually, a refractory fluid overload was a really quite common finding in patients recruited to this study, which is a predominantly surgical population. And so maybe there's a signal here that giving renal replacement therapy to treat fluid overload is beneficial earlier, whereas giving renal replacement therapy just to treat a high creatinine earlier is not necessarily beneficial. In this context, I'll move on to one of the other timing studies, the Ideal Icu Study, which was looking at a different patient population, one with septic shock with no benefit. And the problem with patients with septic shock is obviously that while they may have fluid overload, it's going to have been more chronically acute during their illness than in somebody who's just had major surgery or trauma. And it may be more sequestered in vascular beds and more difficult to resolve. But particularly in the Ideal ICU study, there was a relatively high reliance on intermittent hemodialysis as a primary modality for the treatment of RRT, despite these patients being sepsis patients on vasopressors in the majority. And one might argue that the hemodialysis delivered over a period of 4 or maybe even up to 6 hours would not be an optimal treatment to resolve fluid overload, because that would demand a high rate of ultrafiltration. And so that potentially could explain why you might not see a benefit in this group. But I think overall the conclusion would be, if you want therefore to look at benefits of RRT, you should be looking at RRT as a method of targeting fluid overload rather than looking at an AKI criteria as a method of initiating it. So really, as I've said, we may have to forget creatinine-based definitions of AKI and consider what you might call our standard indications for AKI, for renal replacement therapy would be. And it may be that fluid overload is one of those, presumably occurring in the context of some degree of AKI, but as perhaps a better indication of a failure of the supply-demand balance of kidney function in the context of critical illness. Obviously, there's the option to give patients diuretics at this point, and we've got to consider the pros and cons of giving RRT versus a trial of diuretics. There isn't time to discuss in great detail diuretics in this context. In particular, I'm not going to discuss the furosemide stress test, which is really a standardized trial of diuretics, but really talk about them more in general. Therapeutic benefits have never really been sustained in clinical studies. Historically, they're studied for the prevention and treatment of oliguric renal failure, and that may be an area where they're doomed to fail. And there is good evidence of lack of benefit in other situations, such as contrast nephropathy and in some surgical settings. But again, these may not be contexts where, in fact, fluid overload is the major problem. And so if you take a circumstance where fluid overload was potentially a problem, as in this analysis of the FACT study looking at patients with ARDS in the ICU, really diuretics were a very important part of the protocol of this study in order to achieve a restrictive fluid balance as opposed to a liberal fluid balance, and which was the management intervention in this study. And as you can see here, there was a good separation in fluid balance, and the good separation in fluid balance was largely achieved by a much greater cumulative dosage of furosemide in the restrictive fluid group. Overall, the study didn't show a benefit in terms of survival, but did in terms of dependence on mechanical ventilation, which was not the primary outcome. But there was a sub-analysis of this study, which is relatively complex, but it's kind of comparing the effect of the diuretics and the actual fluid balance that was achieved. And to cut a long story short, in the restrictive group, being exposed to a greater dose of furosemide and having a lower level of fluid overload were significantly associated with improved outcomes. So it may be that if you give furosemide to treat fluid overload and you achieve a better fluid balance, then that improves your outcome. But we really need to test that more fully. So diuretics should be given fluid overload, but we don't know how to predict responders versus non-responders. But it may be a simpler matter of doing a protocolized challenge, which might be something like the furosemide stress test, which is delivery of an 80 to 120 milligram bolus dose and assessing the diuretic response with careful appreciation of the hemodynamics. And really what we want to do overall is we don't want to delay RRT, because we do know the patients who are given late RRT have worse outcomes. That may be causation or correlation, but it's probably not something we want to encourage. So patients need to have a standardized approach, and I would urge people to develop one. When we move on to RRT, then there's a very mixed picture about how we should achieve ultrafiltration, because really we're getting here to the same dichotomy we have at the original element at the beginning of this talk, where we're talking about the balance between resuscitation and avoiding fluid overload. Here we're talking about resolving fluid overload and versus precipitating intravascular hypovolemia or recurrent low-grade shock as we achieve ultrafiltration. And the evidence is interesting here. So this is one study from the Pittsburgh group, where they were looking at patients with fluid overload in the ICU and looking at the level of ultrafiltration was applied to them, which is obviously going to be linked to their level of hemodynamic stability, but is still also an intervention that they've been given, albeit not randomized. And they stratified into different groups of ultrafiltration. And what they found was that patients who received less than 20 mils per kilogram per day of ultrafiltration in the context of fluid overload had a worse outcome. And that was significant in an adjusted analysis for the high versus the low intensity group. So really, there were some differences in the illness severity here that sort of abrogated some of the effects, but there certainly was a dose response effect in terms of ultrafiltration in patients already with fluid overload. But this is obviously very difficult to interpret overall, because different patients in the bedside can have different tolerances of fluid removal, and that may also reflect their outcomes due to things that are not actually caused by the intervention. So this is another study from the same group in collaboration with Ronaldo Bellomo's group in Australia, reanalyzing the results of the Renal study, which was a RRT dosing study from over 10 years ago now, where they looked at ultrafiltration rates that were delivered in this study and divided them into different terciles of ultrafiltration rate, here measured in mils per kilogram per hour. All these patients were treated with renal replacement therapy. And what they found here, and this is from the supplement, but it shows the individual kind of net ultrafiltration rates, is there's actually a kind of perhaps a suggestion of a U-shaped relationship with mortality, that very high ultrafiltration rates were associated with worse survival, but perhaps the lowest ones were also associated with worse survival as well. This is perhaps not unexpected, but it's again reinforces the fact that there is a balance between the circulation and the degree of interstitial fluid overload that is very difficult to meet in the management of our patients. So this is the results of the study, but really let's cut to the chase. Among critically ill patients with acute kidney injury were treated with vena-venous hemodiafiltration, ultrafiltration rates greater than 1.75 mils per kilogram per hour associated with increased mortality. And really, this leads us to reflect again on what's actually happening in our patient. So this is a cartoon from a review I wrote a few years back. And really what we have here in the critically ill patients, and particularly these septic patients, is a situation where we've got interstitial edema, fluid accumulation, systemic inflammation, rapid loss of fluid from the vasculature in a degraded glycocalyx, really reflecting the rapid rate of fluid loss from the circulation. And in at least the glycocalyx model of the fluid balance between different body fluid compartments, most of the return of fluid to the circulation is via lymphatic return, which is going to be relatively fixed and will actually be decreased in the context of severe interstitial edema and critical illness. And so when we perform ultrafiltration, or indeed when we perform diuresis, we're removing fluid from the circulation, and that will be done in the face of a fixed rate of lymphatic return and the effects of any other fluids you're giving back to the patient. And even though there may be a large excess of fluid overload in the tissues, our ultrafiltration may still cause intravascular hypovolemia during its application if it is at too rapid a rate and exceeds the rate of vascular refilling. And because that is predominantly dependent on lymphatic return, because the glycocalyx is degraded in critically ill patients, that can be very challenging and really prevent us from using high rates of ultrafiltration. And so that inevitably means that addressing fluid overload is lengthy and has to be performed carefully. So decisions in prescribing ultrafiltration, we need to think about the goal, the extent of fluid overload, what euvolemia might mean for our patient. But as I've said, we really need to think very carefully about the tolerance of fluid removal, rates of vascular refilling, the ability of the circulation also to tolerate transient reduction in intravascular volume. A hemodialysis patient may be able to withstand rapid fluid removal during an intermittent dialysis session when they turn up. They may not feel well. They may need to have cooled dialysate. They may even get transient myocardial ischemia, all of which has been well demonstrated in many dialysis patients, but they'll survive it. But our critically ill patient on vasopressors certainly won't have the circulation to withstand intravascular hypovolemia, and so we shouldn't potentially re-shock our patients. And so we need different ultrafiltration profiles for different circumstances. And I've discussed this many times before, but this is a dynamic process over time and needs to be modeled to the situation. And it needs individualization of therapy. And it may need levels of hemodynamic monitoring that you might also apply during resuscitation to deresuscitation. So to conclude, managing the critically ill patient involves this existential conflict between the need to resuscitate cardiac output and the inevitable sequelae of fluid overload. While fluid overload is to some extent inevitable, it doesn't mean that it should not be recognized, mitigated, and managed. This might even require early recourse to RRT, particularly if fluid overload is refractory to a standardized diuretic challenge. And this is particularly important because even relatively modest UF rates may be independently associated with harm, potentially reflecting continued risk of hypoperfusion due to slow circulatory refilling. And therefore, it may be better to use either diuretics or renal replacement therapy as a method of preventing fluid overload, because it may be much more challenging to use it to treat fluid overload. But it's a very dynamic situation. Our ICU patients are on shifting sands. This is particularly true in our COVID-19 patients who have a high risk of acute kidney injury, have severe lung injury, are very risk of the ill effects of fluid overload, but actually might be often intravascularly deplete when they present to hospital after being unwell for some days, at the point where they don't necessarily have severe septic shock per se, and in need of overt and their needs for fluid resuscitation may be difficult to evaluate. And so there may be evolving evidence about this in the future, but I'm afraid that it will never, I think, result in a one-size-fits-all recipe. And I'll conclude there.